Hi, I'm Eddie Patton, a practicing neurologist here in Houston, Texas, and current chair of the Board of Medical Economics for the Texas Neurological Society. I'm excited today to bring to you this edition of The Business of Neurology. The Business of Neurology is a video series that's dedicated to helping the neurologists in Texas learn more about the business aspects of practicing neurology. This series is sponsored by the Texas Neurological Society. Today we're going to talk with Dr. Rita Achary about alternative practice models such as subscription practices and concierge neurology. But first, let me tell you a little bit more about Dr. Achary. Dr. Achary has over 25 years of clinical neurological practice. She specializes in nutritional neurology. She's the current president-elect of the Texas Neurological Society. She has numerous publications and presentations on the topic of how nutrition affects neurological conditions. Dr. Achary decided to depart from a more traditional insurance-based practice to a somewhat more subscription-based practice. Today, we're going to talk with her about how this new practice style has enhanced her neurological practice. So, let's go over and talk with Dr. Rita Achary. All right, well, excited to be sitting here with Dr. Rita Achary, and I'm going to call you Rita because we've known each other for a long time now. If that's okay, of course.
It's absolutely okay. We're old friends, and I'm so happy to be here.
Absolutely. Thanks for having us. Thanks for being here, rather. Now, Rita, you have been in practice for over 25 years, and I know you started out practicing in more of a traditional insurance-based model and then have moved or shifted to a subscription-based model. So tell me a little bit more about your journey through practice and how you decided upon your current practice style and model.
Sure. So, actually, I started in practice 25 years ago, right? So I finished my residency training here in Houston, and I did my epilepsy fellowship, and then I went into practice, into private practice. My father is a neurologist, and he was in practice as well on the west side of town. So I joined him, but I think the very unique and positive thing about that was that his practice remained on the west side of town, and I developed my own practice in the medical center, right? So it allowed me to really see what it took to introduce yourself to the community, to develop and grow a practice. So I did hospital and clinic work, I think until 2012, when the landscape of medicine, of neurology changed quite a bit with neurohospitalists, telestroke, and it was difficult for private practitioners to go into the ER. The requirements of having to be there in 30 minutes didn't quite fit with having an orderly day of outpatient clinic. So, and I missed going into the hospital, I have to say, but then I started just a pure outpatient practice. My practice has always been enhanced with EEG. I do EMG, I'm fellowship trained in neurophysiology, and I'm also trained in neuroimaging, right? So since the start of my practice, I have been not only ordering MRIs on people, but I have been reading, interpreting, and being compensated for that. So I've always had sort of a few enhancement that's been positive for a private practitioner. At the end of 2019, the start of 2020, my father decided that he was probably going to slow down. I think he knew what was coming in the future of the pandemic. So I rebranded in 2020 to be, I'm a solo private practitioner. I changed the practice name to Integrated Neurology, not integrative, right? I'm not an integrative doctor, but the integrated talks about doing clinical neurology, having all of the elements of neurophysiology and neuroimaging that I can do for my patients. I also have been, over the last 15 years, developing what I call nutritional neurology. Neurologists have been involved in nutrition for many years, whether it's B1 deficiency and beriberi, or B12 deficiency and memory disorders or neuropathy. Many of our disorders are actually nutritional. And so I've added that as an enhancement that I offer my patients. So that's sort of been my journey over the past several years, actually, past decades. We know that reimbursement for patient care, and especially in cognitive specialties and now in surgical specialties as well, has been declining. And it presents a very real challenge on how to keep independent practice alive. And so that has been sort of how I got to where I am.
Excellent. So tell me a little bit more about the subscription model specifically in neurology, and why it was such an attractive model for you, and why maybe an attractive model for other neurologists.
Right. So for all of us, right, in independent practice, it is about staying alive, right? We have to make our practices thrive so that we can adequately care for our patients. Through the last couple of years, one of the things that I was noticing with reimbursements decreasing is that I was having to see more and more new patients on a daily, weekly basis, which meant that my patient volume was growing, and I'm very fortunate that it is growing. Unfortunately, if I'm seeing 20 new patients a week, my existing patients can't get in to see me for 8 to 12 weeks. That's not good delivery of care. That's not good patient care at all. And so I thought a lot about, well, what could I do? There are no real organizations like MDVIP, right? MDVIP is a concierge medical service mainly for primary care physicians, and they have a model for primary care physicians. But there's nothing for specialists, really. There's another organization called Special Docs. I had spoken with them, and these are organizations that go out and then survey your patients to see how many patients will stay with you if you decide to go into a subscription model. So I researched that for a while. I talked to a lot of people, not only here but in other states, and I started to discover that there were several neurologists who were doing things differently, who had a subscription model or had a direct pay model, and some who were considering concierge models through independent companies. So I started to do my own analysis of my practice.
Okay.
My practice is different in that about now 7 years ago, I opted out of Medicare completely.
Okay.
Right? That is an unusual thing for a neurologist to do, and I understand that.
But more and more neurologists are thinking, or at least going down that road.
Well, you know, I opted out of Medicare for several reasons. I think at that time, RAC and MAC had come in. There was a lot of, you know, sort of, you could get into trouble without ever doing anything wrong. And I thought, this is not the right way. And actually, it was one of my patients who's an attorney who said, you got to get out of this. You know, if something happens and you're taken out of practice, you're not going to be any good to anybody. So I slowly transitioned out of Medicare, letting all of my patients know this is what I was doing. We kept our fees exactly what we were being paid, right? They weren't, but you know, my patients have a contract with me that they will not bill Medicare for any of the services that I provide. And so it's cash. It's a very reasonable fee, and most of my Medicare patients have stayed, and actually my Medicare age practice is growing.
Really?
So yes, and so this is a cash business, and I think that patients are looking to spend time with their physicians, and in neurology we need more time. We're not primary care, but we are principal caregivers. So when you give somebody a diagnosis, whether it's migraine in an 18-year-old learning how they're going to deal with it in college, Parkinson's disease, Alzheimer's or epilepsy, you are the primary caregiver, I should say principal caregiver
like
for
that
that
term.
patient, right?
Yeah.
We are principal caregivers, and our patients require a lot of time, and patients want time with their doctors. I cannot do that by, increasing the volume on a daily basis. So anyway, as I was searching through all of this, I realized that I had enough of a patient volume. I've been in practice for 25 years. I take care now, if you include my father, 4 generations of people in Houston. So doing my own analysis, I thought, okay, we can do this. So I have a very reasonable yearly fee for patients who have been with me for a long time. For new patients, because we are specialists where we may see somebody with carpal tunnel syndrome, diagnose it, and it's done. Or with a lumbar radiculopathy, and you make the diagnosis, send them to the surgeon, they're fixed. They're done. So we don't necessarily need them to be with us for a year. So I also have a quarterly payment plan. So you can just come, see if you like me or don't like me, let me make the diagnosis, and when you're occasionally cured, isn't that nice in neurology?
Yeah, absolutely.
Then off they go, right? So we've got a lot of flexibility for the type of patients that we see. After 25 years, those patients who cannot continue with me, anything we do where finances are involved, there will be disparity because there will be people who cannot afford to be with me.
Sure.
I will say that those people that are in my practice who, as I say, have grown gray with me, I have a group that are membership exempt. And so these are the things we're allowed to do in private practice.
Excellent.
And so, and if somebody has significant financial challenges, we're able to waive the fees for them. So I'm practicing the ways that I've always practiced, but now I have secured an idea that I will have however many 100 patients I will take care of in a year, but it gives me, a 30-minute follow-up visit, an hour-long appointment, and there are things that I offer with the nutritional neurology part that are also enhancements. I don't necessarily need to do that to do my model because I'm opt-out of Medicare, but that is something that you have to have if you're going to go into more of a concierge model.
So let's talk a little bit more about those 3 things, 3 buckets, and a lot of people get confused because there is some overlap between concierge versus. So if you could, for the viewers, just give an overview of direct patient model, subscription model, and concierge. What are some of the differences in the 3?
Right. So let's start with the direct pay model. Now, for neurologists, and there are several neurologists here in Texas and Austin doing this. There are neurologists all over the country doing this. Direct pay for neurologists means essentially a cash model, right? Okay. So if we're talking about primary care physicians and perhaps for neurologists who take care of memory disorders or epilepsy, it may apply. But primary care physicians, when we talk about direct pay, they are given the patients are charged a yearly fee, and for that yearly fee, they get a certain number of visits, right? So, and then, you're able to give them a super bill and they can go and be reimbursed by their insurance company, or it can go towards their health savings or a flex account if they have one. But
now, are labs and other services like imaging, different things, are they covered under that as well, or do you still have insurance that are covered? Okay.
Right, labs, any kind of labs, imaging, other, x-rays, anything, are usually not covered. The only part of the direct pay model is what your interaction is with the physician, right? So it is just us. So that's direct pay would be, in neurology so far, basically a cash model, right? And it seems to be working well. I have spoken to 2 neurologists in Austin who are doing this, 2 young, fantastic neurologists, and they're really loving it. They are able to provide good care. They don't have to hire a giant staff to go through insurance. They're running a lean, patient-focused practice. So, it can be done. The concierge model there is, in internal medicine, the biggest and most well-known company is MDVIP, but there's another company called Special Docs. And Special Docs is venturing into the specialist areas, but they don't have any neurologists yet. So, but they're in contact with several, and I spoke with them. They're very nice people.
They're interested in neurologists.
They're interested in neurologists. So Special Docs operates on a concierge model. So that assumes that you are in Medicare, that you accept other insurances.
Okay.
And when you do that, then you have a contract with your patient, and your patient pays you a yearly fee. So Special Docs goes and canvasses your patients, and then you decide what fee you're going to charge and how many patients you will keep on your panel, right?
Okay.
So it's anything from the MDVIP $1,500 model where, you know, remember that MDVIP takes 30% of that.
Okay.
So, and Special Docs takes a large percentage too, but you know, it can be anywhere from $1,000 to $10,000, where people keep a very small panel of patients. So there's a tremendous variety and variability. Within that, there is an assumption that because you are part of Medicare, you must provide a service that Medicare does not pay for.
Okay.
Right? So for internists, that is a yearly physical.
Okay.
It may be a nutrition consult. It may be all these things that Medicare doesn't pay for. And that is what that fee covers. Right? So if you are going to accept Medicare and do a concierge or even a subscription model, which is what I'm calling mine, you must provide a service not covered by insurance. And that is the enhancement.
Okay.
Right? So many of the...
And for you, that would be the nutritional neurology.
For me, it's the nutritional neurology part, you know, and, you know, I develop recipes for people. So I was talking to a memory care neurologist the other day who said, my biggest problem is in patients with advanced dementia. How do we keep their calories up, right?
Exactly.
Well, I developed a recipe for a higher calorie without all those processed and preservative ingredients of Ensure. So we can, and we can tailor it to what people like.
Absolutely.
Because when you get into those situations, you know, the sensory changes in terms of taste, trying to find something that is palatable. You know, we want to keep people with the best quality of life. So all of my cooking, and my friend who's a chef says I'm a home chef. I think of myself as a home cook, but I've been developing recipes for a long time. So that's another enhancement. I can, you know, I can take teenagers who are going to college and say, how do we get you the best meals? I've spoken to, we're diverging completely here, but I've spoken to cooks at fraternities, how to source things so that everything is more nutritious for my patients.
Okay, so if you are, in the concierge model, if you are taking Medicare, you have an enhancement that has to practice. And it sounds like there is some overlap there between these different models, and you can make it personalized to what you want to do as a neurologist, to so to speak.
Yeah, that's exactly right. I think there are many models out there. You can mix and match through them to suit, you know, the kind of practice that you would like, but also what is best for your patients, depending on, you know, what type of patients, what area of town, what area of the country you serve. And, you know, I think both of us were at the resident luncheon, and that lovely young neurology resident who is going into an underserved rural area to start her clinic there. But in my conversations with her, she is very clear that she's going to be able to make a good living. These are her charges, and that's how things are going to go. Now, with that, being able to survive as a neurologist and thrive as a neurologist, now that gives you time to deliver free care, charity care, whichever, to diverse populations, it frees you up to go and do the things you're great at doing without having to be a slave to this, seeing 100 patients a week. Eddie, I look back when I started my practice, and I was going to 3 hospitals in the medical center plus TIR. I was the neurology consultant at TIR, and then I had an office in the medical center, and 3 afternoons a week I officed in my father's place on the west side of town. I was seeing, easily 70 patients a day. Wow. I started super early and I finished late at night. And I would be eating a cheeseburger Happy Meal as I drove from one place to the other. I don't think I ever sat down. But as I look back, I think, was I really delivering great care?
Yeah.
Can you do that? Can you spend 15 minutes with a patient, a neurology patient, and deliver good care? And I don't think you can. And so I wonder what I was doing, and I think I've evolved to this after multiple pressures, but also having a good contemplative time to say, what are we doing in medicine? If we're not happy, our patients are not happy. Absolutely. And our patients are happiest when they have time with us, unrushed time with us, right?
And physicians are happy when they can deliver that type of care. I mean, that reduces burnout and everything else.
Exactly. We don't have our noses stuck in a computer screen. You're spending time really getting to know patients, right? And patients want to know you, so that one-on-one time. Great patient care is delivered when good time is given to the patient. It can't be done in a hurry. And our models are all, whether it's fee-for-service or quality-based, where we're typing in metrics for population-based care. Well, population-based care is probably not great care, right? Mm-hmm. Great care is personalized care.
Absolutely.
And that's what I'm hoping to provide. And I hope more neurologists will find a way. Those who want to be an independent practice know that there are ways to do this, right? Okay. And
that's great. So you spoke a lot about a lot of the pros, and it sounds like a very attractive model and allows a neurologist to have that time with patients. But what are some of the cons or negative aspects of one of these alternative models?
I think the main con is access, right, for our communities. Whenever you create a financial burden, there are going to be a part of the population who will not be able to see you. Mm-hmm. So cost is cost. We have that even now in patients who have a certain insurance plan. I used to, when I was a teenager, my dad started in private practice, I used to go answer his phones and in the summertime. And somebody would call, and we'd pick up the phone, we'd say, Dr. Achary's office. They would say, I'd like to make an appointment with the doctor. And you said, yes, of course. And what time would you like to come? And of course, there was a book. There was no computer back then. And you would write in legible hand on the day, on the time. You would write down so-and-so, you write their phone number, and that's it. Mm-hmm. These days, a patient calls, the first question we ask, what insurance plan are you on? Yeah. Right? And then your front office proceeds to probably ask, mine certainly does, everything so they can fill in the EMR. Every person along the way, before you get to the doctor, even though we have HIPAA, knows why you're coming to see the doctor. Right? Your medical information isn't private at all, just in making an appointment. Yeah. So those are there are problems inherent in the entire system where if you don't have, if you have insurance, you're dictated as to where you can go based on whether the doctor accepts the insurance. So that's already there. If you don't have insurance, you're in trouble anyway, right? So if you have a ACA plan, many people are not on it. So I don't see the cons as being any different than the current healthcare model. As someone who's been in practice for a long time, one of my cons that I'm experiencing right now is explaining this to my patients.
Sure.
Who've always gotten everything. They've gotten the enhancement, they've gotten access to me, they've gotten, you know, I have no nurse, I have no MA. They have me for a long time. So many of them are not going to be continuing with me. So it's a heartache and a heartbreak, but we have in the city of Houston so many fantastic neurologists. You know, we have a great community here. So I am leading them to excellent neurologists that they will fit in with. But that's a con. I'm losing people that I've taken care of for a long time, but I'm also gaining a lot of people in the process. So that's the biggest one, I think, is just limitation.
Okay. And we, you know, as a part of this video series, we look at all different types of models, from academic to employed, and now direct care, concierge. For the neurologists, and you've been in both models, you know, economically, how does this model compare as far as the bottom line for neurologists? Can neurologists be both happy, as it sounds that you're doing, and can it be profitable for them?
Well, the answer to that is a resounding yes. And we know that, you know, neurologists come to things slowly, right? We're slow adopters. Usually the cardiologists have done something and it trickles down to us. Well, in this case, the primary care physicians have been doing this for 10 or 15 years. So this model not only works, this model is proven, this model is acceptable, and what it allows you to do is decide how many patients you are going to care for in a given year, or, you know, continued. It will allow you to then say, okay, this is how many patients I need to care for to pay my overhead, including my staff, my salary, and then, you know, do I want to do more than that? Do I want to do just that? It gives you a lot of freedom to decide. And so it gives you not only financial freedom, but it gives you temporal freedom. You have time with your patients.
Wow.
So
that's so important nowadays.
It is. It is. You know, we were talking, I was telling you about my Medicare patient population growing. Part of the reason is they don't get time with anybody.
Yeah.
And they're complicated patients. As we get older, all of us are getting older.
Absolutely.
You know, we don't just have a headache or something that can be quickly done in a 10 or 15-minute appointment. You know, we have diabetes and high blood pressure and high cholesterol, and then we develop the consequences of peripheral neuropathy, if we've had a stroke, if we have TIAs, if we've got cerebrovascular disease of various kinds, memory disorders. There's so many things, and those require time. And family members, you know, when we take care of patients, if you're taking care of somebody with Parkinson's disease, you know that their family, their children, their grandchildren also want some access to you.
Sure.
They want to understand that illness. So we spend a lot of time with caregivers and families that we have never been compensated for, and this allows us compensation for that time.
Well, this has been an exciting interview, and hearing about this, hearing about your practice and how you practice, and making that decision to switch to this model. But any final thoughts you want to leave with the neurologists, the viewers today?
Yeah, I think that one, independent practice is not dead. It's thriving, and we can actually make it thrive. And it may be, I think it is, the best way to care for patients, where there's not so many pressures on you as the physician so that you can take care of patients in the way you want. The second thing is that to avoid physician burnout, you know, match day, medical school match day was recently here. And I have a lot of young students that I have mentored, and they're matching all over in so many different specialties. And it always makes me think about the joy with which we entered medicine. You know, we wanted to save the world, right?
Absolutely.
The only thing we wanted to do is care for people. This gives you the opportunity to do that. It brings joy and time back into caring for people. So, and I think that's so important. And finally, that, you know, medicine it's a sacred charge. And we should not, we have allowed in part, but all these pressures that have come onto us, that we need to somehow break free of that and remember that, as I've said earlier today, that really good medicine and great neurology, which we've got a lot of great neurologists, we're so fortunate in this community, happens with time spent with the patient, and there is no substitute for that time.
Well, Rita, I really appreciate you being here and sharing this knowledge. So if there are neurologists that are thinking of one of these alternative models, you know, what's the best way for them to get started, or resources that they can look into?
You know, we don't have anything well defined, and you, of course, in your groundbreaking series that you're doing here, are actually one of the first places I think we've talked about it. There are other neurologists, I think, who'd be very willing to chat with people. I am available as a resource, and I'm also gathering some information on other physicians who are acting as consultants to develop this kind of thing. But I'm available, you know, through email, through phone, whatever anyone would like, but I'm always happy to help answer more questions about this.
That was great. Maybe you can help, maybe we can post some things on the website and as well for the Texas Neurological Society website.
I'd be delighted to share that information.
Thank you so much for being with us today.
Thank you, Eddie.
And dropping such wonderful knowledge to our viewers. So thank you so much.
Thank you, and I'm available if anybody has any questions about these models.
Thank you all for tuning in and joining us for this edition of the Business of Neurology. I really appreciate the insight that Dr. Achary shared with us today on alternative payment models within neurology and alternative practice styles. Please tune in to the Texas Neurological Society website to view this edition and future editions of the Business of Neurology.